first decline to see if anyone had a case they had prepped. Otherwise, I would love to get people's takes on this one as a potential discussion today.
Is into the undiagnosed case. Okay, if anybody changes their mind, it's not too late. Hi Marcella, hi Ravi. Ravi, actually, yes, and we would love your and everybody's help. Would anyone like to kind of take a slightly more active role and discuss Steph's case with me? Otherwise, it's gonna, if not, then it will remain an undiagnosed case.
Also, if no one else helps Zavin, it's just like a regular dinner time conversation between us. No, just kidding, which would be a lot of fun to have your guys input, but yeah.
Well, I'm sure people will still blow up the chat.
Yes, absolutely.
And help you solve the case. Okay, let's do this. But please, along the way, even if you didn't feel up to taking the full discussant role, please don't limit yourself to the chat. And if anybody wants to kind of express a more free-flowing or complex line of thinking, please do so.
All right. The concern is a 2-week leg ulcer. But let me give you guys a bit of the story too. This is a 28-year-old woman who's really kind of been in good health for most of her life. 3 years ago, because of some syndrome of chest pain and a rash, doctors told her she might have lupus, but she doesn't know anything else, was never put on any immunosuppressant medications, and that was sort of that. Over the last 2 years, she's had right greater than left leg swelling on and off. And when the right leg swells, she notices she gets some lymph nodes in her groin that then go away when the leg gets swollen. And she hasn't gotten any specific medical care for this symptom. She came in because over the last month, the right leg has been pretty swollen. And in the last 2 weeks, actually an ulceration has formed on the right shin that has just gotten bigger and bigger and more painful. And that is what finally made her come into the emergency department for evaluation. So let me stop and get your guys' thoughts on that thus far.
Steph, just to clarify, you said that she feels lymph nodes in her groin and then the leg starts swelling?
No, I would say she noticed when the leg is swollen, she notices she can kind of feel some lumps and bumps in the groin, but then when the leg gets less swollen, it goes away. So, but hard probably to say based on the story if there's a causality there between them. But this leg swelling really has been on and off both legs, but right more so than left. And it is the right leg that has developed this painful ulcer over the last 2 weeks.
So, I mean, I think of ulcers in some broad categories of vascular, arterial, venous, vasculitic, infectious, and can also be malignant. But the intermittency of it, right? And the fact that it comes, there's this context of preceding swelling and then the ulceration.
Can I clarify one thing? She never had the ulcer before.
Right.
The ulcer is just in the last 2 weeks.
It's the swelling that has been coming and going. In
Yep.
this case, the swelling came and then became an ulcer.
Yep.
That really seems like it could be a venous ulcer. We'll see how it looks and whether it's sort of typical or severe or has some features that might be more suggestive of kind of a primary infection. But the background context is one possibly of some hydrostatic kind of changes in the venous pressures that cause the edema, and then have now progressed to cause skin ulceration over the area that seems to be most involved with this venous hypertension. So I'm kind of putting the ulcer, that's the, again, chief complaint, it sounds like, and it's more prominent and out of proportion to the apparent venous insufficiency or hydrostatic changes. But for now, from what I'm hearing, it's like, okay, that's a secondary thing. What's actually causing the swelling and the lymphadenopathy? And for that, I mean, most causes of leg edema, if you think about it, don't come with lymphadenopathy, right? You have heart failure, you have, venous insufficiency, venous stasis, you have DVTs, and most of them don't have lymph nodes associated with it. Certainly not that patients can feel, right? So this is definitely sort of, I think, stands out to me as very significant and potentially relevant. And the question is it a primary sort of lymphatic lymph node process, some inflammatory condition that is causing lymphadenopathy, sort of lymphatic obstruction, and that's what's causing the edema? I think the timing here matters, where, if I guess this is the only time that she has the ulcers, but I would also want to be careful not to flip the causality, right? Like, what if the edema came first, she developed an ulcer, and then the lymph node is actually reactive to, some inflammation or infection related to the ulcer? But it sounds like she's had lymphadenopathy intermittently before she ever had ulceration.
Yes.
So how do we problem represent? Let me see what helps we have in the helps
in the help chat. Yes. So Hans, yeah, I think just you're thinking about the ulcer itself. It was actually framed really when we first met her as, oh, this could be cellulitis with kind of a weird component. So that's certainly epidemiologically most likely. But yeah, with some of these other systemic symptoms, that really is what made us think about lymphatic disorders, malignant disorders. And then Ravi, you're bringing up a great thought about why is this leg swelling on and off to begin with? One of your favorite teaching points is physiologically the left leg should be a bit more swollen, right? There's a little bit of natural compression of the left iliac vein by the right iliac artery crossing over. But in this lady, it's always the right leg. So Ravi, I think you're bringing up a great thought about, is there something anatomic that's actually predisposing this right-sided predominant swelling? A really great thought.
But it's both, right? It's both. It's just a right worse than
more. Yep.
Worse than left.
Yep.
I'm also curious, has she exhibited any of these abnormalities, lumps, bumps, swellings outside of her lower extremities?
No. Nope.
No. How are y'all able to kind of tie in the history of this, like maybe lupus with an episode of chest pain and rash? Could lupus or a related disorder present with this? Yes, no, maybe.
Great point, Rafa.
For sure. Rafa, yeah. I agree. I would think it would be diffuse too, but we don't necessarily know that it's not right now, right? So she could have diffuse lymphadenopathy, And the intermittency of it, could just be sort of with undulating disease activity, that is typical of a lot of autoimmune disorders. So it's definitely intriguing. I would want to hear more kind of details, get records if possible, get a better description of like what was this rash, right? And if it was like a classic malar rash, right, and the chest pain was like classic kind of serositis, then maybe we're building a narrative over time here. And I think we definitely have enough to sort of go after that really thorough review of systems history, but as well as already checking some serologies.
Let me give you guys some more then. Paloma, to answer your question, I didn't ask years ago when she was given this possible lupus diagnosis where the rash was. I think it was kind of across the abdomen and legs, but I actually forget the details of that. Although I think characterizing whatever that episode was years ago is really important. Hans is making a good point about a painful ulcer is actually an important thing, thinking about what are the possible etiologies, including vascular. And then, yeah, Ravi's spot on about things that can ulcerate that don't necessarily have to do with the blood flow system at all. So let me give you guys some more information. She's got no other medical history that we know of. She takes no medications. I will say she's had one normal pregnancy and has a 4-year-old child. No family history of any early age malignancies, autoimmune conditions. She works in an office and has no health-related behaviors related to tobacco or alcohol use that kind of fit into her health history, no known allergies. Let me give you the physical exam and then probably just the first few diagnostics, including basic labs that we had from the emergency room. Her vitals are completely normal, including being afebrile. She generally looks well, looks like a healthy person. Lungs, heart, abdomen exams, completely normal. She does have some right greater than left lower extremity swelling. And it pits a little bit, but this is a little hard for me to say. It's not kind of the doughy swelling that I'm used to seeing, for example, in someone with decompensated heart failure. So, her sock makes an indent, your finger makes an indent, but like the legs kind of just look like a little puffy almost, but there is a little bit of pitting, I will say. And then most prominent on the right shin, I tried to get a photo which I can't pull up right now. Sorry about that. There is this probably 4 centimeter by 3 centimeter, like necrotic ulcer. And you can actually see there was a bit of a black eschar on it that a little bit has fallen off. And like, you can see fat underneath this ulcer. It is extremely well circumscribed, very, very painful to the touch. She's got no joint inflammation, no oral or ulcers, no other skin lesions on her face, extremities, arms. And the basic evaluation we have thus far is a normal white count, hemoglobin of 7.5 with a very low MCV of 62. With iron deficiency, that was actually checked already on admission. Ferritin of 60 and iron sat of 6%. Normal platelets. Normal basic metabolic panel. Urinalysis that has 30 milligrams per deciliter, a very, very lowest present amount of protein, no red blood cells. PTT that is a little bit elevated to 39, a normal INR, and a leg ultrasound that does not show a clot on the right leg, the right veins, from common femoral vein all the way down. And that is how we kind of meet her in the hospital setting. I should say HIV negative also.
Wow, no wonder you wanted to share this case.
That's
and
why
get
I
some
need your
input.
guys' help.
What ideas do y'all have? Pyoderma, infectious things. So same as just sort of associating. You hear, kind of black necrotic looking, solitary skin, right, lesion, and what we would call an eschar, and you think of certain infections, anthrax, some rickettsial stuff, tularemia, I would add to that list, right? Fungal things, Hans is bringing up, and Ravi, yeah. Anytime you see black, right, kind of necrosis, it's sort of vascular and specifically arterial vascular things kind of come back up again. Calciphylaxis is one process, but we should kind of discuss more the possibility of vasculitis. Because I think now that, the way that the ulcer looks, it seems like it's out of proportion to just the degree of venous pressures there, right? Like how many people do we see with lower extremity edema and elevated venous pressures? And, sure, sometimes it causes some inflammation, right? Often it's more diffuse. It just looks pink, can almost look like cellulitis. And sometimes it weeps or ulcerates, the skin breaks down. But it's, to have such a well circumscribed, very painful, and black borders, or black throughout?
No, the border isn't, it's the scabbing on the top had gotten black,
Yeah.
but when that falls off, you see fat
Adipose tissue
underneath. Yeah.
Yeah. So I think my initial impression is we can't stick with it. And I think it needs to be framed more as just a, solitary, extremity ulcer. So to kind of think through some of the, possibilities, I think the infectious things are good to think about. It's, very discordant is basically her otherwise well appearance, right? For all of these things, all of these kind of atypical infections that can cause these eschars, you should be systemically ill, right? So I think it would be very surprising to me if she had an atypical infection with an entry point this advanced to not be febrile, sick, ill, have other lab abnormalities, etc. I think I saw somebody mention ecthyma gangrenosum. That's when you have, gram-negative bacteremia that essentially sort of spreads, embolizes, metastasizes to the skin, and can present with small kind of black necrotic kind of papules, vesicles, pustules, sometimes nodules, but this, again, there's sort of a discordance with the systemic illness that you would expect with that condition. Sort of talking about kind of microvascular, not like named arterial disease, but dysfunction of smaller arterioles. Calciphylaxis was mentioned. That's when you have calcium phosphate precipitation in the vessels. The better term that I like is calcific uremic arteriopathy. And you don't have to have advanced renal failure necessarily to get calcific uremic arteriopathy, CUA, but you do want to have some metabolic abnormalities or high calcium phosphate product to have the substrate for that process, which we don't have in this case. But otherwise, if you didn't know the labs yet or know the history of the patient's background yet, the way that the lesion is described is very typical for calciphylaxis, right? And then, small vessel vasculitides, we expect to have more of a petechial purpuric rash, right? But medium vessel vasculitides can present with nodules or ulcers. And I I think everything has to start somewhere, and you could potentially have a, a solitary ulcer. This doesn't seem like a malignancy just by, sort of context and rate of evolution and stuff. And then could some of the neutrophilic dermatoses look like this, whether pyoderma or, Sweet syndrome? Usually it's not as sort of like ulcerating necrotic up front, right? I would have expected to have a more sort of infiltrative nodular red erythematous initial appearance, and then you can ulcerate. So, but by the way, did it just like start with an ulcer and it spread? It wasn't
So,
something else and then ulcerated?
It was a bit of a red bump first. And actually, what I'll give you guys for the next aliquot is we get additional backstory about the evaluation she's had on the past, as well as photos from her phone. That's one of my favorite. One of the best things about technology, route patients often have photo documentation of things have evolved. And so that showed us there was a little red spot that then got ulcerating for this lesion.
Interesting. So I mean, I think neutrophilic dermatoses are in the differential for sure. Let's see what help we're getting from Ilya on the infectious causes.
So Hans is wondering about, inflammatory markers. She looks well systemically, doesn't have a white count, but that is coming in our next set of labs. We did check in ESR and CRP. And I can tell you they were high. The ESR was greater than 100. The CRP was 13. Ilya, she was never prescribed any medicines for this question of lupus 4 years ago. Whatever the syndrome was, she was told the doctors thought it might be that, but was never put on meds. I have more information, Khalid, on the kind of evaluation of the hemoglobin, because that caught our eye. I don't know if you want to comment on, she was iron deficient based on a ferritin, but anything else to say about that?
I would love to comment on it. So I think this is one of those challenges that's really important to try to discern, like, signal versus noise, right? So, and the other one is like the very minimal protein in the urine, which is worth quantifying. I think that the dip on the UA, is a very crude instrument. But, somebody who's inflamed like this ESR of 100, no matter what is going on, you might expect to be spilling a little bit of protein, but basically, is that a signal for a glomerulonephritis, right? Or some nephrotic process, glomerular process. So I'm kind of holding that in a parking lot too. But the anemia is, notable. Okay, on the one hand, she's a young woman, and it would definitely be, by the way, very helpful to have an idea of how heavy her menstrual sort of periods are, and whether she's struggled with anemia, iron deficiency in the past. She's iron deficient, but you can be iron deficient and not profoundly anemic, which she is, right?
Yeah.
So I think it's important to realize that, like, the iron deficiency doesn't necessarily sort of like put to bed this question of the hemoglobin, especially because in the differential of lower extremity ulcers are also hemoglobinopathies, right? With sickle cell, you can have ulcers around the ankles and the lower extremities. And part of that, by the way, I may be misunderstanding it, but I think of it as, also sort of like a vascular process, right? It's vaso-occlusion, it's ischemia, it's hypoperfusion, necrosis, et cetera. So I would calculate what's it, Mentzner index with her RBC count over her MCV, and see if there's sort of like a disproportionality of the microcytosis to the anemia. Do you happen to know where it was, north or south?
I forget. I mean, I didn't think to calculate it, and I can't remember what her red blood cell count was.
I see. But I think, doing a hemoglobin electrophoresis, I mean, it's easy, and we might as well. The ESR is very notable. Obviously, there's a severe systemic inflammatory disorder going on. The ESR is this high. TB, myeloma, osteo, vasculitis. And then the CRP is elevated, but maybe not as elevated as the ESR, and that's sort of a unique pattern you sometimes see with SLE, right?
Yeah, that's right. I remember a prior case, I can't remember if Ravi presented or who, but it was exactly that slight discrepancy in the inflammatory markers.
So I think you want to move
Yeah,
it,
let me give you
along?
guys a little more info. I think the thinking is beautiful. We were really still at this point wanting to make sure we didn't miss any atypical infectious process, thinking about what systemic inflammatory disorders in the non-infectious category of both vasculitides and connective tissue disease, as well as trying to make sure kind of we weren't missing a potential malignant trigger. The kind of one point I want to make, I think pyoderma gangrenosum was really kind of something that I was concerned about, seeing this lesion and hearing about its evolution from a bit of a mass to a necrotic area. And about 50% of pyoderma gangrenosum is just idiopathic its own, but 50% is associated with autoimmune conditions, hematologic malignancies specifically, malignancies specifically hematologic, and then very rarely other conditions like sarcoid, et cetera. So even pyoderma itself, right, isn't necessarily the end diagnosis, as others are saying the iron deficiency itself isn't an end diagnosis. So there just kept being more threads to pull on. Her renal function was normal. The answer, her BUN and creatinine were completely normal. So let me give you a little more. So I'm going to give you additional history we got from her, as well as outside records, and then a few more diagnostics. So we asked her about menstrual bleeding, and she says she has had quite heavy menorrhagia for her whole life. And doesn't sound like she's ever been put on oral contraceptives or anything, but menorrhagia is definitely present. We get some outside records actually from the other place where she was evaluated. And what we find out is she had a positive ANA, but we do not know the titer. But that's kind of where this question of lupus came from. So some positive ANA. That right lymph node that she's noticed on and off was actually biopsied and just showed reactive lymphadenopathy, including flow cytometry was normal. That's kind of, we also hear that she was seen in this kind of facility for two transient episodes of face and lip swelling that went away on their own on one day. So we don't have any more information about the chest pain or the rash that led to the lupus diagnosis, but we know some positive ANA, reactive lymphadenopathy in the right groin, and 2 bouts of transient swelling that they thought were kind of maybe allergy of the face and lips, went away, never recurred. This is all 4 years ago. I gave you guys the inflammatory markers. We order an ANA. It is still not back yet. So I cannot tell you what her ANA is now. We do a hemoglobin electrophoresis, actually, wondering about hemoglobinopathy playing into this. It is completely normal, has normal fractions of hemoglobin A, A2, fetal hemoglobin. So she doesn't have beta thalassemia, doesn't have sickle cell. Whether there's an alpha thal trait is possible. And then finally, this kind of question, I think Ravi was commenting in the back about why is the right leg always more swollen than the left, kind of bothered us. And so we actually wanted to get venous imaging higher up than the common femoral vein. And so ended up getting a CT venogram that actually showed normal iliac anatomy, no compression at all of the right iliac vein, but showed the unexpected finding of diffuse bony sclerotic lesions, pelvis, upper femurs, and we end up getting a plain film of the leg too, sclerotic lesions everywhere in her bones. And that's where we are today.
What?
And this is why I need all of your help with her. Oh, can I just bring up Ilya's point too? Let me give you a bit of diagnostic info, and that is around the abnormal PTT. We did a mixing study and it corrected immediately and at the 1 hour afterwards. So mixing study normalized that PTT.
Wow. So if it hadn't, just to be clear with everybody, you can see an isolated elevated PTT when you have antiphospholipid syndrome. That in vitro activity prolongs the PTT, the lupus anticoagulant, but obviously it's a prothrombotic state, and can present clinically in a lot of different ways, some of which are kind of we've discussed as possibilities. So it seems like that was, especially with that very mild elevation, maybe that was just a false signal. Sclerotic bone lesions. What are y'all thinking?
Hans, you may suggest a bone biopsy. Yes, I think we're going to need that, and we do not have that yet. But yeah, what are these? And they're sclerotic. They're kind of build up bone as opposed to lytic, kind of broken down bone.
And radiographically there wasn't like I guess it was diffuse, a lot of them.
Yeah, the pelvis, the femur, everywhere, like all the bones that we got on this CT venogram had sclerosis, and then we did plain films of the leg, sclerosis, ankle, foot, fib, femur.
Was her calcium normal?
Her calcium was normal. Yep.
So sclerotic bone lesions, obviously when we hear a bunch of stuff in a bone, the first thing is malignancy, right? And which Sabai, if I'm guessing what you're thinking, that's kind of where you're coming from. Breast cancer metastases can be either lytic, usually I think they can be blastic as well, and more sclerotic, and prostate cancer is the classic one that tends to cause more sclerotic bony lesions. When you have like an isolated kind of sclerotic or a couple of them, the most common thing when I've talked to radiology or seen their sort of report, so-called bone islands can appear that way, but in this case it seems to be a very diffuse process. So either this is either a very widely kind of metastatic process, or it's sort of a metabolic disease of the bone itself. Paget's, but I'm sure there's a long list that I've like never heard of and don't have good ideas of. For some reason, like those kind of like histiocyte disorders are coming into my mind, with like a skin thing, systemic inflammation, bone lesions. Does anybody know more about various Langerhans and other histiocytoses?
So someone can, so I think bone stuff, skin stuff, right? Just that histiocyte proliferative process is important. So Langerhans histiocytosis comes up. People can definitely verify this looking online. I didn't see an association between pyoderma, which is our working diagnosis for this ulcer, although we don't have a skin biopsy back yet. The rash of Langerhans histiocytosis is very often a bit more diffuse and papular, but I have not looked up if there can be an association with an isolated ulcerative lesion. But that whole category of kind of cell proliferative diseases, tumors that aren't quite malignant, kind of popped into my mind with these very diffuse bony findings.
I saw a lady who had Langerhans, and her skin lesions were like very beefy pink papules, and in limited locations, like in her groin. But honestly, I've always struggled sort of with my illness script for that class of disorders. Seema, can you tell us more about Erdheim-Chester? I know it's a related disorder, but
what I remember when it comes to Erdheim-Chester, I always combine it. I feel like it's a non-Langerhans cell histiocytotic disorder, and usually the involvement of the bones is bilateral, what I remember, and they also have usually lung involvement. That's what I remember.
Wow, Ravi's link is the title is quite intriguing.
Yeah.
So what's the what do you think the next steps should be, y'all? Tell Steph what to do.
Hans, I'm with you. We're gonna get a bone biopsy. So kind of characterizing what's in the bone, I think is going to be an important part of this.
What about biopsying the ulcer?
We've got a biopsy of the ulcer.
Oh, you already have?
Yep,
Oh,
no
perfect.
results back yet. Kirtan suddenly appeared, filling in the
Really? I summoned Kirtan just
yes
by,
with a tough
or it
tough
wasn't,
case.
it wasn't, it was you summoning Kirtan by my
Yeah.
action.
Yeah, I guess the other kind of question that came up in my mind was, could sarcoid overlap with this? Now, the bony lesions of sarcoid, guys, correct me if I'm wrong, are not always sclerotic, but can be. I should have mentioned that this is a young Black woman, so that just might be relevant epidemiologically. And there is a rare but present association between pyoderma. Again, we don't know that this is what that is yet, but if it is, between sarcoid. So we're actually, her chest x-ray, I forgot to mention, was totally normal, but we are getting a chest CT. 90% or more of sarcoid should have some lung or hilar lymphadenopathy involvement. So just to sort of fill out what other, if the lungs are involved and if there's other organ involvement, we are getting a chest CT in addition to waiting for the skin biopsy to come back and having her get a bone biopsy. Our ANA is not back yet, although it was sent, and you guys have beautifully thought through kind of the other vascularity evals we've thought about. We have sent a ANCA, although again, Zavin makes the point that this larger ulcer, we think more with a medium vessel vasculitis involvement, but we did send an ANCA. There's no kind of risk factors or pattern that she would have chronic hepatitis that would predispose her to cryoglobulinemia or anything else, but we do have chronic hepatitis serologies pending as well. And the antiphospholipid antibody panel, the beta-2 glycoprotein, as well as the anticardiolipin, even with the lupus anticoagulant or the PTT correcting without the lupus anticoagulant.
I think sarcoid is I'm glad y'all are going in that direction. We should have mentioned it earlier, even just like with the lymphadenopathy and the chest, that episode of like chest discomfort rash, it's
yeah. And a question I'll ask you guys, as a team, we wondered, is there a role to rebiopsy that right inguinal lymph node, which I should have mentioned kind of once the imaging showed that lymphadenopathy was prominent, it really was noticeable or is noticeable on exam when we go back. I'm curious what you guys think. It has been biopsied before and it was reactive with normal flow. Would you add that now? And I'm curious why or why not.
I have an opinion. I want to hear if anyone else does. No, I think probably not. I mean,
Yeah.
it's probably a systemic, it's one process. You've biopsied two other things, and then lymphadenopathy, I mean, very likely is again going to be reactive. So I would probably just go stepwise personally.
Yeah, we're holding off right now, but I think if we don't get answers from the diagnostics we have, it's another potential area. That's where we are with the case. I am happy to update you guys on where we go with it, but I found it an interesting situation for a few reasons. A very prominent kind of subacute or acute skin symptom on generally the background of someone who's pretty healthy, but has had kind of intermittent unexplained symptoms, right? The leg swelling, lymphadenopathy on the past. So I think we're going to find a systemic kind of autoinflammatory, autoimmune disorder in the background. I luckily for her think malignancy probably just doesn't fit with kind of the time course of what happened years ago that is likely contributing to now. Although it makes me a little bit kind of nervous with the new ulcerative lesion, if that could be a symptom. But I think hopefully our tissue diagnostics will start putting us in the right direction. Yasmin, that's a great point. Ulcerative sarcoidosis. Well, I think this is another, I think a case also where it's going to be very helpful for us to talk proactively with pathology, both her bone and her skin interpretation, to make sure they know we're worried about histiocytic disorders, granulomatous processes like sarcoid. I think using the pathologist very, very actively as a consultant on this case and making sure they know what we're worried about, hopefully could make either of these two biopsy sites diagnostic in the end.
Wow.
That's where we are right now. Thank you everyone for your thoughts. Just so helpful. All of the kind of cases that you guys have found online and just general pearls about how to interpret this skin finding is incredibly helpful. Seema, should we turn it over to you for a summary of some of the teaching points?
Sure. So first of all, thank you so much for this great case. Also the amazing discussion. I took so many notes also from the chat. So coming to some quick teaching points. So if we have like ulcers, the systematic approach we have is it any vascular issue? So with the arteries, is it something venous or vasculitides? Could it be something infectious, a malignancy or autoimmune? Then we were also collecting some differentials like some vasculitides, lupus, and so on. And then if we have a unilateral leg edema, we should think of venous insufficiency, lymphedema, and there was also several times mentioned the elephantiasis, which is due to an infection with filarias. And then also lymphangitis, cellulitis, DVT. And then we were talking about the black Escher. I hope I pronounced it correctly. And the three main infective agents that come into my mind are rickettsia, scrub typhus, or anthrax. Also think of tularemia, fungal. And then we also learned about uremic calcific arteriolopathy as another word for calciphylaxis that can also do this. And also ectema gangrenosum due to pseudomonas and also gas gangrene. And then thinking about the vasculitides in terms of the middle vessel vasculitides, you would rather expect nodules and ulcers, and for the smaller ones, more petechiae. And if we have a microcytic anemia, we are always thinking about iron deficiency, but we know there are so many other reasons for it. And there's this nice pearl that I learned today. It's the Mensner index. So we have the RBC and the MCV index. And if it's above 13, it's rather an iron deficiency mediated. And if it's below 13, it's thalassemia. And always remember that antiphospholipid syndrome can cause an isolated elevated PTT. And when it comes to these sclerotic bone lesions, thank you so much, Kirtan. We should always think of something like a malignancy, and especially something like prostate cancer metastases can cause it. Also think of infiltrative diseases like Langerhans, histiocytosis, Gaucher's disease, Erdheim-Chester. And we were also coming to think of these autoinflammatory disorders like Schnitzler syndrome, which usually presents with an M gradient, and this urticaria, and also mastocytosis, POEMS, and also think of Paget's disease. Yeah. I would stop right here. Thank you so much for listening, and hope to see you again soon. Thank you.
Seema, thank you so much for that excellent summary. It actually, listening to you go through everything and looking more thoroughly at Kirtan's help, mastocytosis, both of us, just thought of when we heard those like episodes of facial swelling, and I wasn't sure. I was actually Googling to see if it's been associated with ulcers, certainly bony disease, but Steph, you decided that it's worth.
I think, yeah, at least starting with tryptase evaluation and thinking about,
Cool.
Yeah. Thank you, everyone. I will close the loop with you on this case. Really appreciate your help, and have a wonderful rest of your Wednesday.
Bye, everyone. Thanks for joining.
Bye.